Hi everybody, welcome again to another issue of Beers with Jeff here. We are taping on a particular issue called Prior Authorization, and to help us out with understanding the topic, we have Dr. Peter Graham. He is the Executive Medical Director for Physicians Health Plan here in Lansing, and we are drinking Mule Beer from Short's Brewing Company. Really good, actually.
Very tasty.
Lime and ginger, does taste a lot like a Moscow Mule. So.
And it's on a copper can, no less.
And it's in a copper. Yeah, we're really this beer is winning for the day.
Nostrovia there.
So, Dr. Graham, we brought you here to talk about a specific program that Physicians Health Plan has put into place regarding prior authorization. And for the folks out there, prior authorization falls under a category in healthcare called utilization management. This program really started kind of back in the 1960s, became really a health plan responsibility somewhere in the 70s or 80s, where we're using medical staff employed at the health plan to review high-cost drugs and review high-cost surgeries that surgeons and other doctors have prescribed for their patients. These are mechanisms to help keep the cost of healthcare down. Recently, there was a study by the GAO, the Accountability Office, regarding a Medicaid pilot, and this pilot had about 7 programs in it in a few different states, and they estimated it putting prior auth in place in Medicare saved somewhere between $1.1 and $1.9 billion. There's also, these programs have been put in to not only control costs, but to help control waste in the system. There was a study recently from JAMA that quoted that 25% of services in the healthcare system are in fact wasteful. So these are programs that are really important to a lot of our employer clients because our plans are doing their best to be a steward on behalf of the financial dollar that employers are investing in their employees. So, but our plans are independently taking on a role in looking at their own prior authorization processes, and Dr. Graham's company, Physicians Health Plan, won an award recently, and we thought it was good to have him kind of help educate us on the topic, educate us on the why of what they did, and how it's really been effective. So I think maybe first, Dr. Graham, if you don't mind, what kind of doctor are you, and then how did you end up at Physicians Health Plan? And I think one of the things that's been interesting with the legislation, you are in fact a licensed physician in the state of Michigan, correct?
I was the last time I looked.
Okay,
so
good.
That's very recently, so yes, I'm a licensed physician.
Okay, so how'd you end up as the medical director at PHP?
Yeah, kind of a winding road. I'm a family physician by training. I still teach residents at the Sparrow/Michigan State University Family Medicine residency. I don't have my own practice anymore. I haven't for a couple of years just because of the administrative load. But yeah, I started in practice with a Sparrow affiliate practice back in 2001. And I think for a combination of reasons, I seem to have a higher tolerance for meetings than most of my colleagues. Kind of angled my way into being medical director of the home care agency that Sparrow owns. And I guess I did something right. An opening came up at the health plan back in 2005, I think it was. I went over. I was there at halftime. I was halftime practice, halftime there for about 3 years. Was executive director / VP in charge of the employed physician group at Sparrow until 2013, early 2013, came back to the health plan, and I've been back there ever since. So kind of happened by, I don't want to say by accident completely, but it kind of feels that way. And if somebody had held a gun to my head when I was a med student and said, "Are you going to be a medical director administrator?" I don't think I would have said yes, but here I am, and it's an interesting life.
So that also means that you're keeping your finger on the pulse of what doctors need, and you know specifically, having worked in that area, like what doctors need and what sort of help they need, especially in the area of utilization management, prior authorization.
Yeah, I try to very carefully keep that connection, and part of it is, our plan is a provider-sponsored plan. We're wholly owned by Sparrow Health System, so even if I didn't care, believe me, they're going to get my grill work if I'm not paying attention to physicians and clinical reality, as they should. And we have to be a good partner to them as well as all of the other providers in our network and all the other physicians and nurses and everybody else. I think it's really important in my role to keep a good grounding in clinical reality for a couple reasons. I think you tend to make better decisions on both a micro and macro scale, and if you're remembering the reality that everything we do in a health plan ultimately translates to some human being somewhere has a need, and remembering, for my part and for what I end up advocating for, is that physicians, and I will die on this hill, 99.9% of physicians are doing what they do or want what they want for good reasons. We may not always see eye to eye on exactly how to get there, but they are staring at a patient, they're seeing reality that I'm not seeing, and I need to rely on them and know how to work with them. My CEO has been very, very good about this, both him and his predecessor. I'm pretty insistent that no matter how busy it gets, I want to keep that clinical contact and part of my life, just so I continue to know what that reality looks like, and what it's like to be on the other side of the fence.
Yeah.
Yeah.
Dennis actually touched on that a couple days ago at Crane, so it's a very consistent message from your organization.
I'm glad I didn't just talk over my boss, so we're off to a good start.
Yeah.
But yeah. Okay.
So on that note, you undertook this program to take a look at prior, specifically, I believe, on drugs.
Yep.
And why don't you tell us kind of the why you got there, and then
Sure.
maybe what the results were, and then I think just maybe the overall happiness maybe on both sides.
Yeah, it's I think a good story because it's illustrative and it has a nice happy ending too, at least from our point of view. Ongoing, it never really completely ends, but I think it helps. You did a nice job of kind of teeing up what prior auths are and why they exist. I think it bears remembering that that you focus rightly on cost, and I won't shy away from that. It's one of the things we really are charged to focus on. As I remind my physician colleagues from time to time, it's not my money. It's and really, it tends to get easy to think in those terms. If it were my money, it'd be easy just to give it away. Well, maybe, but it belongs to employers. It belongs to individuals who are paying premiums, and in the case of Medicare and Medicaid, it belongs to the government. So it's basically all of us. So we have to be good stewards of that, and not really going to shy away from it. But, and I think you made an oblique reference to this, it's sometimes also about safety, and it's also about efficiency and duplication or non-duplication of care. And I would conservatively say for at least our plan, patient safety really has to do with cost.
Nice.
Or with, protection of or conservation of a scarce resource. So if you have particular medications that are either in shortage or hard to come by, that's one of the reasons. So anyway, looking back to, I guess it was late 2015, 2016, we actually started this project and got the data collated by 2017. They were relatively small plans, so these are relatively small and relatively flat staff. So anytime something needs to happen that involves a human being, it is an expense to us, it's a cost, so aside from human factors. And we also realized it was a friction point with our practitioners. We do keep a pretty close ear to the ground, both qualitative, what message we get back from provider relations staff, what I hear in the doctor's lounge, what we get out of our, sometimes that's really colorful, by the way, but what we also get back out of formal surveys of physicians, and consistently, and this is true across the industry, one of the things that physicians have the hardest time with, dislike the most, are prior authorizations. We're saying inside the plan, we don't really love them either, and I think it's an important part of this conversation for folks to kind of understand. Anytime you do a prior authorization, that's staff time. It's kind of an opportunity lost because you're working on that instead of other things. And if it's not working at peak efficiency, it gets very expensive. So we took a look at, what is the total universe of things that we're requiring prior authorizations on? How do we move things off? And I know that's one of the things that MSMS is, the Medical Society for the audience, and physicians have often asked is, how do you determine when things are no longer needing a prior auth and the rest? So really figured out how do we systematize that, and then take a look at, we've got accreditation guidelines. I think most people forget, most health plans have a lot of people looking over our shoulder too. We have a license from the state. We're accredited with URAC, which is along with NCQA accredits most of the health plans in Michigan. I think all of the MAHP plans are URAC or NCQA accredited. And they have pretty specific timelines for completion of those for just the same reason. It's an important quality metric. You really need to get those done on a timely basis because you don't want to delay timely care. Yeah. And just from a human point of view, as I kind of harken back to, you really don't want people having to wait unnecessarily for something that's, obviously they're not having a good day, right? Yeah. I mean, if they need a medication, it's not because something's going great in their life. It's a either acute or chronic health problem that they need help with. So we took a look at that, realized our benchmark turnaround time was, we were within the guidelines for accreditation, but it's still kind of long. It took us kind of in the neighborhood of 10 to 12 days to turn around a claim, which, is kind of pushing the outer limits, but that's a long time. And again, if you think about that patient sitting there waiting almost 2 weeks to get an answer, that physician, who's wanting to take care of somebody waiting that line. It's just not good. And as we looked internally at how much rework we did inside the plan, mostly in the form of either the prescriber's office calling up and saying, hey, what's the status on this? Or sometimes the patient or the member, it just created additional work that, if you just start to unpack it, really probably didn't need to happen. We did the good old fashioned, I know it's kind of buzzwordy, but it really worked. It was kind of a cool process. Did the Lean Six Sigma.
Oh.
Let's take a room.
that makes my heart feel good.
I was gonna say I couldn't tell if that had hurt or if that was good. But,
no, I'm a Lean Six Sigma guy. Yeah, I've got a black belt, so I definitely get the idea of process control and sitting there looking at the measurements and saying, okay, this needs to get down to a certain level for us to be happy to benchmark.
Exactly, and kind of taking a look at it from that point of view, and then really walking through the entire process and doing the whole Kaizen and laying it out start to finish. How does this actually happen? And found a lot of points along the way. It's like, why are we doing this? We found redundant processes. We found unnecessary processes. And then it's kind of another dimension of that. Let's take a look at the entire set of medications that are on the auth list. What really needs this? What can we kind of monitor on the backside? Short story long, I know I've kind of gone on at length about this, but we were able to implement most of those changes. So a pretty immediate drop. We got down to about 8 days, and as of the last measurement, I think I told you coming in, last reliable measure, we're down to about 3.8 days or so for average turnaround for our PAs.
So Physicians Health Plan took a look at your processes. You got your feedback from doctors. You took a look at everything you were doing, and this is not only a patient safety but a cost issue. And you went from long on a 10 to 12, now you're down to 3.
Closer to 4, but kind of in the neighborhood.
3 to 4.
So we cut it down comfortably by about 2/3.
And your physicians are happier?
That's what we've heard, and both gotten good feedback. Again, qualitatively, we're still waiting. We haven't completed our 2019, or we're in the process of completing our 2019 formal provider survey, but gotten good feedback there and pretty good feedback in our member survey. We do CAPS survey on a regular basis like the rest of the plan is doing. That's one of the areas we've traditionally done really well and done better since we implemented it. And just in terms of direct cost savings, we've noticed that the time and basically freeing up staff, it saved the plan, at least in the initial year, close to the order of $200,000. It doesn't sound like that much to a lot of businesses, but to us it's pretty significant, and that's all cost savings that we can pass back on to the subscribers and the employers that they're not paying for us to be less efficient. So,
well, I think the important thing to note here, I think, is easy. This didn't require legislation. This was you guys you guys listening to your provider community and helping them out and putting something in place that became mutually beneficial for both sides.
Yeah.
So I think that's the win on prior auth, at least in our space. So.
I agree, and I'm enough of a free market guy that I think that it's a great example of don't disincent, because what inevitably happens, this is just kind of one doctor's humble opinion, but I've seen this play out enough times. What almost inevitably happens with legislation is it becomes a ceiling rather than a floor.
Yeah.
And the intention is good, and this is where we want things to go, but then everyone will come in there, or worse, not better, unless you really, really put a hammer on it. We have every incentive in the world to, believe me, we don't exist without physicians. I mean, there's no point to us. We close the doors. So unless we keep them happy and have some reason for them to continue to be in our network, and the same with our members, if we're not delivering what they paid for, they're going to walk away. It's a pretty darn efficient system. I mean, Adam Smith laid it out, 300, almost 250 years ago, and it really hasn't been improved on much. So I think, in terms of how to get there, I'd also be concerned about stifling innovation in the other plans. I mean, we just figured out one way to skin the cat. I know there are a lot of really bright people in the other health plans who have exactly the same set of incentives we have, exactly the same set of concerns, and I'm guessing they may do something even more impressive than we did.
Yeah. Well, it sounds like a great program. We appreciate your time today.
Thanks.
Hope you appreciated the beer. Shorts, again, doing a great job
Highly
with the mule beer.
Not Molly, but Mule.
No, it's not Molly. There's an outtake where I said Molly just for the people out there. So we'll release the blooper reel at the end of the year.
Great.
And it'll be fun. But appreciate your time today. I think I would imagine everybody appreciate your efforts on this project, and it sounds like it's done some It's achieved some great results, and it had a Lean Six Sigma element, which makes me very happy from the side of my business I don't get to use too much anymore. But we appreciate your time. Thanks again, and
Thank you.
thanks for appearing, and cheers.
Cheers.